You join us now for a conversation about CMF surgery and its developments and advancements over the last 20 years. And I have three of the faculty from the AO Davos courses joining me now in the studio. Thank you so much for being here. Hello, Nicolas Homsi from Brazil.
Thank you.
Great to see you. Also, Travis Tollefson from California. Hello.
Good morning.
And also Patricia Stoor from Finland. Hello, Patricia.
Good morning.
We're going to talk about the present and the future shortly. But first of all, Nicolas, can we please go back in time to where this all began?
Yeah, we may back on time talking about orthognathic surgery, maybe almost a century ago when the first osteotomies were planned, some different approaches. So during the 50s, maybe some of the regular osteotomies we use nowadays came from. At that time, the only awareness is on function, not so much on aesthetics, but things are arising to aesthetics nowadays. But in the past, the planning was a little bit different. The planning was too much handy, was based on X-rays, cast models. And I think the great revolution was when some pioneers started doing this surgery from intraorally. This was one of the first advancements. And I think the turning point in orthognathic surgery was the beginning of the internal fixation. So the patients used to have their mouths wired for 2 months almost in the past. And when internal fixation came to the reality, to the day-by-day practice, I think this was a great jump in quality for those surgeries. But at that time, we used it to plan those surgeries, talking about cephalograms and some dental cast analysis, and things start an evolution. And this evolution came to what we have in present, that Travis will mention soon. And it serves as a basis for the future, as Patricia will mention as well today.
So before we do that, you've got a case to show us. So can you take us through that? Thank you.
I'm going to show you like a case that we use it to plan. This is a case treating sleep apnea in the old-fashioned way, using cephalograms, X-rays. Not so old, because this case was treated using internal fixation, but this was how, based on numbers, on cephalograms, on traces, that we used to plan our cases. Of course, they were not the outcomes when we take a look for those patients' results from the past. For that time, it was excellent, but nowadays we see it could be much better with the aid of technology. So this is a case we treated just to enhance the airway for this patient, and the outcomes for the time were really nice. But I think things may be better when applying it to new technologies.
Did it make a big impact on the patient's life?
Yeah, everything we're going to talk on orthognathic surgery makes a great impact on the patient's life. So even chewing, treating the sleep apnea, treating some big deformities, some cleft patients. So orthognathic surgery is on quality of life. So those are not emergency surgeries like trauma, but they are surgeries that produce a great shift on the patient's life. And that's why we are working hardly on that, and working on education, as we're going to present this year in Davos, when presenting 2 courses. That one is an entry level, that we have the intention to give the basis of treatment and diagnosis for our participants, as well as the emerging technologies in the simultaneous course, presenting them, the other group, like the possibilities of working with technology for the sake of the patient's health.
Thank you, Nicolas. Well, that leads on really well, I think, Travis, to where we are now. So can you talk us through that? And I know you have a case to show us as well.
I wanted to, to summarize quickly what I am hearing about the past is the changes that happened that made orthognathic surgery more mainstream were the ability to do these. We're changing. It's extraordinarily impactful for patients. You mentioned the airway. As the jaws are moved outward, the airway improves. For children and adults, this can change lives. Secondly, appearance-wise, it's the most when it comes to aesthetic surgery, a facelift, a rhinoplasty, they're effective, but orthognathic surgery can change a face's proportions like no other surgery. And to see us be able to plan this by the millimeter, the skeletal movements in an orthopedic surgery case are monitored by a C-arm, and to look for where the fragments and the new positioning of the fixations are placed. This is in orthopedic surgery. There's bones that are coming together and being x-rayed to demonstrate. In orthognathic surgery, the teeth are the seat that you base how you realign. And then the airway is the thing that can improve, but the nose and the soft tissues, these are the big impacts. The changes to the face from a profile view is astounding. So one of the things that when I started to do orthognathic surgery in our patients with cleft lip and palate, these children, the changes that come are huge for them. And they're craving that throughout their teenage years. And then they finally become skeletally mature and they can start having the planning procedures. So like a case like this is a young girl with a bilateral cleft lip and palate who has an open bite deformity. And as you can see, the teeth do not align. And so the thing that's changed for us now is we're able to use computer planning. It's very accurate. The orthodontist and the surgeon work together to create, on the left, we see the current state, and then after the osteotomy, the planning has shown where the jaw will land. Then cutting guides are created that show exactly where the osteotomies are, and the next stage is then our placement of where the screws will be placed and where the fixation devices can be applied. This provides then the ability to make slight adjustments and look for problems that might occur during the surgery. I think it makes the surgery more efficient. And things that used to be planned with sometimes in people's offices for 3 to 4 hours of work can now be done on a computer in 20 minutes. Has this improved the time it takes for you to plan your cases as well?
Yeah, of course. Having these aids at hand, this technology, this computer-based planning has changed from the past, because in the past, when you did it the way I showed you, we used to draw manually the plan. We should cut the casts by hand, fix them by glue, and achieve the splints. Nowadays, we are talking about total digital planning, even splintless surgery.
The model surgery went from haptic feedback and positioning to a computerized and an engineer that you are guiding to create the changes. And I think that kind of leads us to what we hope the future could guide us to.
We really are at an exciting time, aren't we, in medicine and advancements, Patricia? I mean, as a surgeon, that must be very exciting too.
Yes, I must say I've been doing orthognathic surgery for a little bit more than 20 years. And when I think back how much it has really changed a lot. Because in most of the patient cases, you can treat the occlusion with only one jaw surgery. But if you want to take the patient's appearance into account, then that's not a good idea for very many patients at all. So what I see that has changed a lot is that we look more at the proportions of the face, the harmony of the face, and we try to make, a slightly ugly, deformative person looking like a nice, normal person. And we take the soft tissue support into account much more. And I think this is really, really important. And sometimes when surgery is being done without taking the proportions into account, then you really can make the case worse. So I think that the 3D planning system has really facilitated us to see the proportions of the face, because, if you do it with a old-fashioned plasticast and articulator, it's really in the surgeon's hand during the surgery to put the maxilla into the right position. Is it too much anterior? Is it too low? Is it too high? So all of this is much nicer, because the better it's planned, the better and easier it's performed, and the better results you have. They're more stable. And also what I find really, really fascinating is that we have a lot of patients with condylar pathologies nowadays. And with the 3D planning, you can really look into the condylar area. And you can decide on beforehand how you can preserve the condyles the best during the surgery. how much you want to rotate them or how much do you dare to rotate them. So I think that we see much less reoperations now. The OR time has also diminished. And even the postoperative orthodontic treatment is shorter nowadays because the surgery is being performed more precisely.
So where do you see the future, Patricia? And you're teaching this in the advanced course as well.
Yes. Well, the future is always bright, I think, or that's what we have to think, that the future is bright. And it's probably easy to be bright in orthognathic surgery. It would be nice to, take a time machine and go back to the future and come back and tell you. But I think that we have a lot of great new possibilities. We have the mixed reality. We have artificial intelligence. What I think myself is that there will be a possibility to collect more patient libraries, patient case libraries, where you can then more easily, if you are a beginner, you can go into those libraries and you can see, depending on the patient's ethnic background, what's the ideal facial proportion in that part of the world. And then, you can have an ideal face that you can start with. Because sometimes in challenging cases, also the 3D planning, it takes a lot of time. So, and then I think that what we need is to have a better soft tissue prediction program. We don't have really one that is, fantastic. So I hope that this is something that the future will bring. I'm also thinking about, nowadays it's fantastic with the 3D planning because we use patient-specific drill guides and patient-specific implants. But when you use those, you cannot really do minimally invasive surgery. Mm-hmm. So, and I think that in the future, maybe we will do less and less big surgeries.
Yeah, maybe a place for augmented reality in surgery. Yeah. That I think what I'm hearing is in those surgeries where you're going to put a cutting guide in, you have to dissect more and have more exposure. There's no minimal access.
Yeah.
But potentially, if with augmented reality, you could identify the landmarks and use navigation to show where your cut and placements will, you can use more minimally invasive techniques.
Yeah. I have used myself navigation in orthognathic surgery just to, make sure that when I started with this condylar resorption and rotation thing that I wanted to be sure during surgery. But what I realized when I used it was actually that 3D planning and patient-specific implants, they are more exact than the navigation right now. But probably this will improve. And I think that navigation maybe has a bigger part of during surgery in the future. And nobody knows. Well, maybe there will be some stereotactic ultrasound possibilities that you don't even have to open the wound. You just make the bone softer and then you have the guides and the navigation, but without doing big mucosal openings. And then what I hope also is that the future will bring us more possibilities to use artificial intelligence for the orthodontic planning. And maybe we will be able to use more segmentation because we still see a problem in patients that go through the preoperative orthodontics that they have root resorptions. And if the preoperative orthodontic was not done really right and you have resorption and you would have to do the preoperative orthodontics differently, then you are in a very bad situation. So we still have some problems that we have to find solutions for, and I think we have good possibilities and chances. And also maybe have new osteosynthesis. Maybe also have a new system for distraction. I don't know. I'm not in the future yet.
If distraction was able to be resorbable biomaterials that are placed after the osteotomies and are activated by themselves, and then the direction of that is completed by having even an iPhone that the program allows you to decide what movement, and then just like the plates that AO has created that gives feedback on tensions within, you knew how much the distraction tension was, and so you adjust then the distractor, and at the completion of distraction, those this is all something we can imagine, right? The distraction arms become the consolidation arms that solidify, and you wait for the bones to heal, and then they resorb, and then another surgery is not required. But these are, ideas for the future?
Yeah, I hope I will be able to, live still for 20 more years.
Yeah.
So then I can
think
about this situation
Yes.
today and see what really happened.
Well, we will see what is next. That has been such an interesting conversation. Patricia, thank you. Travis and also Nicolas. And all the best for the courses and everything that you're going to be doing here in Davos over the coming days. Thank you very much indeed.
Thank you.
Thank
Thank
you.
you.